Okay, so just considering that we have just started recording, maybe we can start with the introductions and presentations. So hello, my name is Andrea Espinosa Carvajal. Welcome to the seminar series, Gender and Health, discussing socialism and transformation after the Second World War. This is the second of 4 sessions. We will be sharing ideas and exploring women's experiences and gender-related systematic transformations in health cultures, political participation, and state building after the Second World War. The idea behind this seminar is to reflect on the role of women and the spaces occupied by women. This seminar is part of the work that we are developing for the project Connecting 3 Worlds, Socialism, Medicine, and Global Health after the Second World War. The themes of today's presentation is women's professional trajectories and care. Today we have 3 presenters to share their research with us. I will introduce them, then we will start the presentations, and we will have the final part as a Q&A after the presentations are finished. Our first presenter is Dr. Reka Krismanics. Hopefully I said that last name correctly. From the Universidad Bielefeld. The title of her presentation is Hungarian Women as Ambassadors of Socialist Medicine, Women Medical Professional Access to an Experience of Mobilization in the Global South and the West in the 1950s and 1970s. She works on the recent history of Eastern and Southeastern Europe in the global context. Our second presenter is Dr. Agata Ignachuk from the University of Granada. The title of her presentation is Socialist Reproductive Medicine, Abortion Reform, and the Provision of Abortion in Spain from 1970s to 1990s. Our final presenter is Dr. Susan Grant from the Liverpool John Moores University. The title of her presentation is Women and Community Care, the Home Help Service in the Late Soviet Period. I think we can start our presentations.
Yeah. Thank you. So first of all, I would like to thank the organizers for inviting me to this seminar. I'm very much looking forward to presenting parts of my research alongside my brilliant colleagues. And thank you for this kind introduction. Yes, I'm Reka Krismanic. I'm based at Bielefeld University, and right now I am in the process of what German academia expects from people during the habilitation process, and that is to move away from their previous methods, approaches, and then to come up with something substantially different from what they have been doing for the PhD. I was trained as an intellectual historian of East, Central, and Southeastern Europe with a focus on modern times, but already during the late stages of my PhD, I started to move away from this approach and did the preliminary work to what became the second major project, in which I am trying to write a history of globalizing Eastern Europe as women's history. And so in the second book project, what I tried to do is to show that gender provides a productive lens through which the connectivity between the socialist East and the global South can be read. And so arguing with many others that gender cannot be divorced from its broader social context, I provide an intersectional analysis of women's experiences from state socialist Hungary as they encounter the global south, with a particular focus on race and class. I zoom in on particular roles and living situations in which these encounters happened, either involving physical mobilities or not. But it's very important that when these encounters involve the physical mobilities, then I rather concentrate on what being overseas means and not focus very much on specific geographical locations, which allows me to bring examples from various subregions of the global south. And since one of these roles that I examine are the roles of women medical professionals, parts of my research do really intersect with some of the major themes of this seminar series. Dora Vargha recently pointed out that Eastern Europe's place in post-war global health history is marginal at best, largely due to Cold War, this vestiges of Cold War logic. And so she argued that by labeling socialist networks deviant or simply disregarding them, scholarship misses not only different practices, but also the diversity of socialist or other ideas that went into the conceptualization and dissemination of socialist health. And these relationships were truly global as they followed the expanding engagement of the Soviet Union and the Eastern Bloc with countries of the global south. By zooming in on Hungarian women medical professionals' access to these spaces, I contribute to filling this gap in the literature by centering previously marginalized voices. And so in this talk, I am going to discuss some characteristics of Hungarian women medical professionals' mobilities in the 1950s and the 1960s, based on diverging and very, very uneven sources. The research on expert mobilities and expertise is a particularly saturated one within the globalizing Eastern Europe literature, and healthcare has been in the forefront of this literature. But similarly to other cases of mobilities, men had a much greater share than women, and so scholars also tended to focus on men's accounts and men's career trajectories. And they did include the occasional woman doctor or nurse, but they did not pay particular attention to them. Yet, as I'm about to show, women were there from the very beginning in these mobility programs, and their experiences were just as formative in how these structures then solidified behind these ever expanding programs, and that this was very tangible both in bilateral types of mobilities, and those mobilities facilitated through international organizations. The WHO is an obvious candidate. And so in my this analysis that I am going to present is based on the holdings of multiple Hungarian archives. Procedural sources are complemented with AGO documents in which women healthcare professionals discuss their experiences of mobilities. First, as the dominant form of healthcare mobilities of the time, I'm going to discuss two major bilateral engagements through the lenses of women's experiences, medical assistance to North Korea and to Algeria. And this will be followed by the discussion of women's participation in application processes for WHO jobs and scholarships once Hungary became active in the organization again. After outlining a paper trail, I examine issues of access and single out some application packages of women for closer scrutiny, and then these timelines, the assistance to Algeria and the WHO, just as I put it on the slide, they will overlap substantially. The wartime and continuous post-war assistance to North Korea made up the first chapter of the work of Hungarian women healthcare professionals in the global south. The Hungarian medical team was the first one to arrive to North Korea on July the 28th in 1950. So the first one from among Eastern Bloc contingents. The physicians, 7 surgeons and internists, and the chief of doctors, they were all men. But among the operating room assistants and nurses, there were both men and women. Actually, 5 of them were women, which means that in the very first cohort of medical professionals providing medical assistance from the Eastern Bloc, we already had women. This gender division of labor, men doctors, and kind of the presence of both genders at the middle cadre level, it remained characteristic of these Hungarian cohorts for the duration of these years, but there were some exceptions to this strict separation in terms of men doctors only. So there is compilation of participants in these encounters, and there we can see that there are 5 women doctors who also participated, one of them actually twice, once in 1953 and once in 1956. And over these years, so between 1950 and 1957, about 200 Hungarian healthcare professionals spent some time in North Korea. And we know very little about their daily lives, but we do have some women-authored ego documents that give us a glimpse into it. We have, for example, Mrs. Dr. K, who was part of the first cohort as a head nurse, and she gave a very detailed account of their arrival and these very dire circumstances, how they had to relocate several times because of the moving front lines. But interestingly, she also added what I put on the slide, that actually she and her woman colleagues were expected to also provide the catering for the Hungarian cohort, and this they found pretty exhausting. For later cohorts, actually, they did have a designated cook, but it must have been a very, very difficult feat to pull. There is the records provided by Miss Aiki, who was the participant of the 5th group in 1953. She provided less of a war-focused account. It was more about really the almost peacetime daily lives of the doctors and nurses. So she said that upon arrival, they chose someone to shadow from the previous cohort before they would have departed. And then they were introduced to the local conditions. She already talked about Korean nurses and doctors who acted as translators. And already speaking Hungarian. She also noted that one of her women colleagues adopted a local orphan, and that she kept this child with her in the hospital all the time. She also described in detail the division of labor that they had, and also talked in detail about the training of Korean nurses, how the Hungarian head nurse had this as one of her main tasks. So this account, and I'm very happy to get back to this in the Q&A, is actually a true treasure trove. But now I will just move on to the assistance to Algeria, which already brings us to the 1960s. So in 1962, Algeria turned to the socialist world for medical assistance and help, and so Hungary responded to this. And the first cohort departed in about a year later in 1963 with 19 doctors and head nurses. This cohort included 2 women doctors and 2 head nurses, actually. One of the nurses was replaced about 6 months later, but it wasn't clear what had happened. Based on the archival sources, I was able to somehow look into the financial part of this of the arrangements of this first cohort. And I was somewhat surprised to see that although the Algerian party was involved in establishing the remuneration of the Hungarian professionals, they were not paid by them, but by the Hungarian state. This remuneration was established and fixed in US dollar. And actually, it was paid in US dollar by the Hungarian state, which is, by the way, just like most of the other Eastern European states, struggled with hard currency scarcity. The Algerian party suggested such a big gap between the doctors' wages and those of the operating room assistants and nurses that actually the Hungarian government intervened and decided to top up that proposed amount. And this ended up doctors receiving $350 per month, and the nurses and operating room assistants receiving $300 per month. This they received on top of their regular salary at their like normal or stable jobs in Hungary. And then the state also paid accident and life insurance. Based on press releases, we have a bit of an idea about cooperation and how the Hungarian doctors and nurses were not only working in the hospitals, but somehow trying to get involved in medical innovation and also attending local conferences. On the other hand, we again have some AGO documents that a little bit give a bit of a taste of the more of the difficult and incoherent parts of life. We have Dr. A.S., who was one of the women doctors arriving with this first cohort, and she wrote a letter about 2 months after her arrival in her own name and in the name of her other cohorts or cohort members. The letter like starts kind of on a cheerful note, but it turns out that there is very little information that they are getting unless they are stationed in Algiers. There is basically no communication between the Hungarian embassy and the doctors or nurses. But then comes the biggest problem, and here I will start the quote, that we have been left here for 2 months by the Foreign Office at the end of the world because they are not interested in us. That's fine. But now we have to borrow money from our Algerian friends for cigarettes, and that is a bit strange. We urge Comrade Rostas to act in our best interest so that we are not subjected to such inconvenience in the future. It's the 20th of May, so we already have 2 months' money hanging between Europe and Africa. So this letter was written to the chief facilitator of these mobilities, and I'm going to talk about him a little bit later. There is a record that actually it really wasn't the fault of Comrade Rostas that the doctors didn't receive their salaries on time. He was petitioning basically the economic office for these timely payments, but somehow it just didn't go smoothly paying professionals overseas with hard currency. And as the last sort of set of cases, I would very briefly move on to the WHO mobilities. Despite the uneasy relationship between the Eastern Bloc and the WHO, by the beginning of the 1960s, the organization became one of the main gateways to connect with Western colleagues for Hungarian healthcare professionals, and to a much, much smaller extent with the Global South. The WHO Scholarship Committee was in charge of everything. They circulated the calls of the WHO in the main Hungarian medical journal, Orvosi Hetilap. It consisted of 10 doctors and the party secretary. They received the applications, reviewed them. They made recommendations to the Deputy Minister of Health, who then made, again, a short list, and this was provided to the WHO, which made the final decision. This Deputy Minister of Health, István Simonic, embodied the institutional continuity between assistance to North Korea and the new engagements of the 1960s. As the minister's first deputy, his role was key in linking the government to these mobility programs. And he also had a trusted associate on the scholarship committee, the already mentioned Oskar Rostas, who also served as the head of the foreign relations group within the Ministry of Health secretariat or later department. Dr. Rostas proved to be an important intermediary as he liaised with various departments of the Ministry of Health in order to prepare and facilitate the mobilities and to support the medical professionals on the ground. These decision-making processes were really convoluted, but as the interest in applying for the various positions grew, they just needed to somehow come up with a more transparent workflow. In the first major round of such applications, there were no women grantees, but we do have the application package of Dr. A.O. from this batch of applications. It contains her references, a letter of motivation, and a short biography. She describes her education, the different stages of her career, while the second half of her letter of motivation, she explains her particular professional strengths and achievements. As a senior research fellow at the National Scientific Institute of Surgery, she participated in the establishment of anesthesiology in the institute. And also she includes very, very prestigious publications. And she also alludes to previous Western trips to Bonn, Cologne, London, and Paris, which shows that really she must have been among the very strong candidates, but again, she didn't win. Those very few WHO opportunities that involved working in the Global South attracted women's applications as well. In 1964, I found a very funnily worded WHO advertisement where they were looking for doctors who would teach stomatology at an Asian or African university. And there, Dr. I.S. and her husband submitted actually a joint application where they very explicitly said, as I included here on the quote, on the slide in this quotation, that they would want to participate in this post-colonial rebuilding and building by getting to do the job. Unfortunately, they didn't win. So Dr. M. Key, she was another woman doctor who applied for the same call. But out of the 16 candidates, they were the two women who applied, but they were both rejected. So some of these application files had been preserved in their entirety, and thus they include these letters of recommendation from their employers, from the personnel department, from party secretaries, as well as the cover letters, list of publications, and the short biographies that the applicants themselves wrote. And there are very, very little traces of these actual decision-making meetings, and these tend to be sporadic and reticent. So by the end of late socialism, thousands of healthcare workers had visited various subregions of the Global South, and their experiences fed into strategic thinking about how the various aspects of Hungarian healthcare, Hungarian socialist healthcare, material and immaterial, could function most efficiently under different climatic, social, and cultural conditions. Beginning with missions to North Korea, women were at the forefront of these encounters. The travels and work of doctors, nurses, and operating room assistants is recorded in EGO documents and application packages where these have survived. Using these sources as starting points, I outlined some of the structures and institutions involved in coordinating the Hungarian medical mobility programs in the 1950s and 60s. During the 1960s, women doctors showed great interest in working in the West and in the Global South, but their actual participation in these exchanges remained below their representation in the professions during this period. This trend somewhat changed during late socialism, but it never kept pace with the increasing, though uneven, feminization of the medical field. On the other hand, due to the highly feminized character of nursing jobs and medical assistance type of jobs, blue-collar mobilities proved to be much more welcoming for women. And my major issue was that detailed reasons for the individual acceptances or rejections were not preserved. And although the outcome of the application suggests a strong preference for men candidates, I could not actually, grasp very explicitly formulated kind of exclusionary practices that would have targeted women and thus preventing them from participating. Thank you for your attention.
Thank you, Reka. Agatha, maybe we can start. Yeah.
Thank you. Okay, so what I want to talk about today is women gynecologists providing abortion services in Spain, legal abortion services. And this is a paper that I'm trying to finish. So I'm very lucky and privileged to be here in this excellent company and hoping to receive some feedback. So this research, the research behind this paper and what I will present today is a part of a project that we are actually concluding now at the University of Granada, which is on the history of legal abortion in Spain. So after partial decriminalization in 1985. And we are sort of trying to move from earlier histories of abortion in Spain that have focused heavily on chronicling the political history of abortion law reform. And instead, we are looking on of the outcomes of this reform, on its implementation and how it configured abortion marketplace and abortion access. And our hypothesis that I think we can confirm with this project concluding is that this access was configured by the interrelation of science of legal abortion, so medical expertise, and specifically the emergence and consolidation of abortion technologies such as manual vacuum aspiration in the 1970s and medical abortion from 1980s onwards. Then social movements, and especially the anti-abortion movement, but also the feminist movement, who is sort of withdrawing from the public debate on abortion after it's decriminalized. And finally, the healthcare services. So the provision, establishment of abortion clinics, the abortion services. And here, in designing the project, we were inspired by the work of Joanna Schoen, historian based at Rutgers University, whose book Abortion After Roe was basically doing that. So looking what's happening after abortion is legal and what's happening, what are the challenges, who is doing abortions, how are the healthcare services established, and what are the challenges. So, and what is socialist about this? So, so I'm not. Spain is we are in the context of democratizing Spain. So the democratic transition, depending on who is defining it, no, it has concluded. But this is a young democracy, and in this democratizing Southern Europe, feminist, but also socialist, formal and informal militancies are key for the things that I'm interested in talking about today. So the healthcare reform, abortion law reforms, and also in abortion services. Our project, we use a wide range of sources. So we are looking at discourses about abortion in the press, both medical press and just daily magazines, daily press. But we are drawing heavily on interviews. So we are drawing on an earlier interview base and from previous his projects on the history of family planning in Spain, and also generated almost 70 interviews with people professionally or on an activist in an activist vein engaged in managing abortion services under the 1985 law. So what I'm trying to do here is sort of link this intersecting sort of spheres of analysis or fields of analysis, which is the healthcare reform, abortion reform, that are taking place at the same time, really, and then what is happening with the medical profession and specifically with women doctors and especially the very, very few women doctors who decide to become legal abortion providers, despite the sort of lack of genealogies for this kind of work within the medical women ethos or history, right? So this is the ambition here. And also I'm sort of like trying to figure out why, despite this concurring processes of advocating for a national health service that materialized in Spain in 1996, advocating for legal abortion or the criminalization of abortion that materializes in Spain in 1986. And despite the very, very intense engagement of the socialist underpinnings of both reforms, there is abortion services, once legal, they are a misfit in the public healthcare, and they are eventually they consolidate as something that's provided in private clinics. And this is the abortion market, the contemporary abortion marketplace in Spain today, under a different law, under a law that recognizes abortion as a women's right from 2010, and then reformed in 2022. And I will sort of do so if I have time. I'll try to not speak for too long, but I have what I'm trying to, by putting these two themes together, I'm also trying to illuminate these the histories of women doctors as abortion providers by looking at professional and activist trajectories of several women who were abortion providers in public and in private healthcare. And I have two examples today, and let's hope I will have time to at least briefly present them. So this is a little bit of what I want to talk about. So just to say briefly a few words about, so there will be a lot of context, just a little bit of analysis in the end, just because I'm looking forward to your feedback and comments. So with the what's going on in Spain in the mid-1970s and to mid-1980s in the healthcare system and in the very idea of healthcare. So this is a very intense period, because during the Spanish democratic transition, the National Health Service project really gains traction and really and starts to be implemented from 1986 with the General Health Law. So substituting progressively the previous model implemented during the late final years of the Franco dictatorship in Spain that ended in 1975. So the previous social security model, sort of Bismarckian model, is there is the Spanish democratic transition. It is one of the key themes, the need to reform healthcare. And the idea of a national health service, so funded through taxes, accessible to all, not only to workers and insured people, and based on hierarchy between different healthcare services, so primary healthcare and specialized healthcare, was heavily promoted and lobbied for by socialist physicians and professionals, both those in medical exercise and those playing more political roles, right? And also part of this reform was a growingly stricter separation between private and public exercise of medicine. So more and more doctors become state employees, and medicine becomes this profession, less of a liberal profession and a profession that's state funded and controlled. And then also what happens is, and there's of course this concurrent dynamics between the healthcare reform and what is happening in the medical profession. But the late 70s and early 80s is a very, very important moment of change because of the massive opening of medical faculties in the second half of the 70s, admission of unprecedented number of students from different social backgrounds. So there is this generation of doctors graduating in the late 70s, early 80s is younger. It's like there are more numerous, the medical profession becomes younger, there are more feminized and more left-leaning than before. So in the so the studies conducted on the medical profession, sociological studies of the medical profession in Spain in the early 80s concluded that almost half of the doctors were under 30. Many situated themselves on the left of the political spectrum, and also over 20% of registered doctors in the early 80s were women. So these changes are, and you can see some more figures on the slide comparing to earlier decades. So this is a quite unique moment for the Spanish medical profession. And many of these doctors, these young left-leaning, some of them female doctors, have this very special relationship to public healthcare. So there is this idea of public healthcare as a militancy, as a form of militancy, which is sort of embodying formal or informal socialist orientation, let's say, right? So maybe without being a militant in a political party, in a trade union, the militancy is being working in the public healthcare, right? And especially the primary healthcare that is being constructed. And this is a super interesting history to be written yet, right? Drawing from Latin American models, Cuban models, etc. So what's happening with, and the other thing is what's happening with abortion and family planning. So I'll just discuss this briefly now. So as you may know or not, in Spain, the national Catholic dictatorship of General Francisco Franco banned the sale and advertisement of all contraceptive methods, and also banned abortion. So this ban was in place, the contraception ban was in place until 1978, and the abortion ban until 1985. But what was happening already in the late 60s, that some usually male prominent doctors in some hospitals, they were starting to provide contraception, mainly oral contraceptive pills, to their patients, and they were specifically targeting poorer women or women, economically underprivileged women with large families, for this kind of therapeutic delivery of contraception. And then this kind of semi-clandestine form of medicalized family planning expanded in the 70s, even before the dictator's death, the beginning of the democratic transition, when contraception was still illegal. Many doctors were doing this in public healthcare, this form of providing contraception to the patients, also to the workers of hospital employees, medical students, and so on. And then after and also in the mid-70s, there is this, so this is sort of one strand, and the other strand comes from the emerging feminist movement. That's also sort of interest in sexuality and contraception, providing feminist groups that are organizing talks about contraception. And then the two movements start to converge in the late 70s with the expansion, really blooming, of interdisciplinary family planning centers. These are not really a part of like this National Health Service that will be formalized later in the 80s, but they are sponsored by city halls, trade unions, political parties, and offer they are like charitable services, interdisciplinary services with male and women doctors, medical students, and often activist women with no prior medical training, sexologists, psychologists as well, to provide this sort of interdisciplinary healthcare, right? In the field of sexuality and family planning. And what's happening to abortion specifically? So this is the very preliminary kind of way to attempt to organize the illegal abortion marketplace. And of course, there was self-managed abortion, perhaps the most dangerous way to attempt to terminate a pregnancy. Then empirical providers who were using various techniques, and many of them maybe offering their services to working class clients. Then there were some usually people with medical training, doctors, nurses, male and female nurses. They were offering their services in cities with higher prices, upper class clients. Then abortion travel was a considerable phenomenon, sort of an open secret written about in the press, almost advertised in the media. And these, as with Cristabel Setta, we wrote about how these referral networks were supporting women's abortion travel and facilitating the access to overseas abortion clinics. And then there was a small number of what I call politicized providers, so people who were either without medical training or doctors who trained in the Karman method, so manual vacuum aspiration, and they were offering services with either this idea of abortion militancy or political militancy. And finally, some of them, doctors were also doing menstrual regulation, so with the syringe in hospitals. So so most of these politicized providers that were doctors were male. So this is when I'm talking about like lack of genealogies. This is also a part of that idea. So in the 1980s, early 1980s, the abortion law reform takes place in Spain. And this is sort of course, a product of a feminist mobilization, political mobilization. Although the Socialist Party that promotes PSOE, that promotes this reform, when it's its majority government that after 1982 elections, the aim was to create a reform that was provide sort of go from this total abortion ban to a law that would seem restrictive, but in practice would allow to resolve most of the abortion demand in Spain. So, and the law was, it was based on three conditions, possibilities. So when life of health or health of the pregnant woman was threatened, if the pregnancy resulted from rape, or if there was a suspected fetal abnormality. But this was sort of frozen because there was an unconstitutionality appeal filed by the Alianza Popular, the Conservative Party, and then finally the law was dictated in 1995. And what happened is the executive order to this law basically restricted the provision of abortion services to public health care because of the sort of how the requirements for facilities, for staff were designed. So small abortion clinics didn't have this equipment, didn't have this this kind of facilities, so officially they couldn't provide abortion services. And then finally, in November 1986, another decree liberated abortion marketplace, so to allow to establish abortion clinics and sort of establishing the abortion marketplace as it is in Spain today. So abortion is performed in private clinics, some of them and especially after the 2010 reform, these clinics can, so women don't have to pay for abortions because they are reimbursed from the National Health Service. But initially this was not so for all the regions, it was rather exceptional. And then the public healthcare does some abortions, mainly in case of fetal malformations. Okay, so now let's move to the examples, and I just have a few more minutes, hopefully, before I wrap up. So my two protagonists here are two women gynecologists, two women doctors. Elisa Sesma worked in public healthcare, and she studied and performed abortions in public healthcare. She studied medicine in Pamplona, and she completed her specialty in gynecology in the public hospital Virgen del Camino in 1982. But also, as she was working, she was doing her specialization. Doing her specialization as specialty. She worked in one of these family planning centers, interdisciplinary family planning centers that I mentioned before. It was called, still exists, it's called Andraise in Pamplona. And then when the abortion was decriminalized in 1985, she, with two colleagues, started providing abortion services in that public hospital in which she was employed. And then almost immediately, an anti-abortion organization, Acción Familiar, filed a claim against her, and this led to a legal prosecution. And while the doctors were finally acquitted in 1991, they had already stopped performing abortions many years before the trial ended, because of series of pressures that they were experiencing in the gynecology service. And especially Elisa, she was very heavily targeted in the anti-abortion campaigns that surrounded the trial. Here you have one example of here on the right of like a small booklet that was being circulated. They say, it says, pray to God for the first, like Navarro, the citizen of the Navarra region who was tortured and killed in his mother's womb by Dr. Elisa Sesma. So this was, she was among the doctors that were participating in the trial. She was like very personally targeted. And when she related, when she was narrating this experience, and she narrated it many times in many different moments, and not only in the interview that we conducted with her, but also published interviews and in books and so on. So she was talking about this. She was not theming it as a gendered vulnerability, but I think can be interpreted as such because of the intersecting pressures in the hospital that both doctors and the women undergoing termination were facing. So the patients were treated as untouchable, ignored by both auxiliary staff and doctors who rejected to engage with them in any way. And there were direct pressures to sort of stop doing abortions altogether. And of course, the trial that had this it was to create this sort of freezing effect and prevent other doctors to engage with abortion services in public health. So when she was talking about why, like she was doing abortions, she decided to implement the 1985 law in her hospital. She was drawing on this family planning experience, on the need to make the commitment and start acting. And it was her turn to act, let's say, and also about women's suffering, underprivileged women's needs and rights, right? And another person that I want to briefly introduce to you is Eva Rodriguez Armario, slightly younger than Sesma, who has worked providing abortion services in private healthcare. So she studied in Seville, this is the south of Spain, and as a student she was engaged with prominent gynecologists doing this family planning, providing these family planning services for even before contraception was legal, and also with some of these militant abortion providers, empirical abortion providers that I mentioned before. And she was this experience of interacting with abortion activists, with self-help groups, was the one that she quotes as sort of foundational for her to decide to become abortion provider. So she started to volunteer in one of the first legal abortion clinics in Sevilla, El Sur, and then after almost a decade, she became the medical director of this clinic. And so, as you can see with the quotes, she was when she talks about her motivation, this is from the drive comes from the women's health movement, and her militancy is about abortion. So she wants to do abortion, and she knows, this is how she narrates the motivation in her trajectory. She wants to do that, like she realized that doing this in public healthcare was not possible, and she would have to provide these services in a private clinic that could work with the public administration, public healthcare, and to sign contracts so the women or the clients would be reimbursed. So just to conclude, so what I was trying to exemplify here are the community, the commonality of women-centered motivations. That in case of Elisa Sesma and other doctors in the public healthcare were more linked to like political social justice ideas, and then with those providers working in private healthcare, more linked to feminist and women's health movement. And of course, there is this idea of survival, let's say, no? So in public healthcare, to continue, the pressure was too high or the environment made it impossible to continue providing abortion services. So, and in the private healthcare, abortion becomes like the center focus of militancy, right? So it is the militancy. So what I wanted to conclude just by showing this diverging itineraries of practice of feminist and socialist reproductive medicine in Spain in the 1980s and 90s. Thank you.
Thanks, Ata. That was really great. Yes, Susan, should we start the final presentation? I hope everyone is taking notes of their questions, so we at the end have a nice conversation.
Can you hear and see?
Yes.
Great. So thank you, Andrea, for organizing this series. So when I was preparing this paper, I realized that I made a rather important omission. I forgot to include old people in the title. So it should really be Women in Community Care, the Home Help Service for Older People in the late Soviet period. This is because a lot of the work that I'm doing at the moment is based on older people in the Soviet Union. So this is coming out of a Wellcome-funded project about growing old in the Soviet Union, where I'm looking at healthcare for older adults in the late Soviet period. And this paper is based on the final chapter of a book project that I'm working on about that issue. And so when I was thinking about this paper and also reflecting on Dora Varga's keynote from a couple of weeks ago, I was kind of thinking about what is kind of Soviet about, what is particularly Soviet about the story of older age people in the Soviet Union, and particularly older age women in the Soviet Union. So this is something that I'll return to at the end. So the healthcare, the home care service for older people was a community-based service, and women were very much at its forefront. And in the context of the Khrushchev and Brezhnev periods, and also into the Gorbachev period, I go slightly into the 1980s in the paper, women were very much active in this period. Elisa Klotz and Maria Romashova have published about these very active female pensioners in this period. And so they were, the old and retired were very active in a lot of these different community services. They were involved in the Council of Veterans for War and Labour, the Council of Pensioners, the Women's Councils, and so on. So in this period, you see a lot of sort of active older women. Around this time, you also had, of course, growing numbers of older people and also shortages of care homes. And this increased the need for nursing and voluntary support. So the proportion of single older people age over 60, this is in the 1959 census, was 13%. And by the 1970 census, this had increased to 19%. By the 1980s, the Institute of Gerontology estimated that some 10 to 12% of those aged over 60 had, quote, partly or fully lost the ability to look after themselves. And this claim applied to 25 to 30% of those aged over 75. And in the Russian Republic in 1985, there were over 200,000 single, old and disabled people in need of this home help service. So it is important to note, and this is something that I think Dora mentioned in the keynote as well, is this issue of population politics. And it is important to note the demographic situation in the Soviet Union at this time. So the Second World War and the loss of some 27 million Soviet citizens created a massive demographic imbalance, right? So women far outnumbered men at this time, and also women outlived men. So when I'm talking about older women, or older people, I am largely talking about older women. But I think it's also important to note that this wasn't a specifically Soviet issue, right? That this was kind of a late 20th century trend that we see happening in other countries around the same time. Chris Phillipson in Capitalism and the Construction of Old Age talks about an age explosion and the population explosion among the old. And again, here, it's women who outnumber men in this over 60 age group. In the UK, Phillips says that women over 60 outnumber men by 50%. So in this paper, as you probably tell at this stage, I also place the home help network in an international context to show that the Soviet system was not out of step with developments in other countries like the UK and the US. And I do primarily look at the UK and US. Community-based activities provided invaluable support to older people, especially those who had, say, chronic illnesses or who lived alone. So in the Soviet Union, then several organizations and institutions played a role in helping older people. This included the Red Cross and Red Crescent Society, as well as the GECs. These were the kind of local housing committees. And they often worked sort of alongside the local polyclinics or hospitals in various neighborhoods and local communities. So just to give you an example of some of the Red Cross work, I've just taken this from a 1959 article in Literaturna Gazeta, which is the literary gazette, or the literary newspaper. And so here the journalist says, look at the wonderful initiative of the communities of the Red Cross Society. They organize special housewife circles for the care of the sick. The women who have finished these courses, and there are already 74,000 of them, make daily visits to sick and aged persons living alone, bring them medicines from drugstores, carry out doctors' instructions, etc. So here, it's the Red Cross Society that's very much involved in these kind of community outreach services and the home help service. And they organize this care of the sick program from the 1950s. It carries on throughout the late Soviet period. And so they encouraged volunteers, housewives, and so on to become involved in this, so that they would be able to take care of those suffering from chronic illnesses or aged people within the family and the wider community. The GECs I will also talk about shortly. So this care of the home, or the care for the sick program, was something that was widely taken up. So by 1966, there were more than 1.7 million people trained in how to care for the sick at home. By 1978, this had increased to 2.7 million people in the Soviet Union. And so it's something that is taken up right across the Soviet Union and in various republics. So this home help service is also something that we see in other countries as well. And again, in other countries, it's nurses and women who are central to this. So in the United Kingdom, it was a district nurse who was, quote, an important liaison between the local authority health department and the family and hospital doctors. And the service, which was free, was sometimes supplemented by nursing auxiliaries who relieved pressure on district nurses through undertaking various jobs like bathing older people, cutting their nails, washing their hair, and so on. And so older people, as well as actually mothers with young children, could expect to receive some sort of prophylactic assistance from this health visitor, whose job it was to help to educate older people and take a preventative approach to their needs. So the UK model of home help was adopted in Scandinavia, where, again, only these kind of housewife skills were required in helping older people at home. And here the service was state subsidized in the 1960s and 1970s. So we see countries around the world so actively seeking different ways to provide home help to older people living alone. And many, of course, turn to women, both nurses and housewives, to provide this care. So I'm going to just talk a bit about a couple of examples. One is from Moscow and the other is from the Ukrainian Republic. So this is looking at the housing authorities, the GECs, which also undertook this work alongside the Red Cross and were involved in this kind of home help service. So this example comes from Timoraysky district in northern Moscow in 1966. And so here, the local housing authorities were stretched in terms of delivering care to older people and chronically ill people in the community. And so volunteers were called on to kind of supplement this work and to help out. And so these include pensioners, housewives, and students. And so this sort of activity, this initiative in the Tymiarski district was covered in an article by Rulyov, who wrote about it in this piece in 1966. And he talks about different examples of this service. And again, it's something that is kind of largely delivered to pensioners by pensioners. So he describes one pensioner who visited a 75-year-old woman living alone, and she helped with cooking, cleaning, and laundry. And then an 8-year-old woman living in the same building benefited from the help of a housewife who was nearby. But he also describes in detail this woman who's described as not particularly old, but very ill, and who has kind of a low pension of just 25 rubles. And so this woman was visited by a neighbor, a friend, who was described as receiving a higher pension and was in good health. And she was also described as kind and generous. So Rylov said that he was sort of describing this situation, and this widow who benefited from the help of her neighbor said that she visited me every day, and she does not live nearby. The hospital is located near the Likachov automobile factory, and there and back takes about an hour. If it wasn't for such involvement, I would hardly get out of bed. So the moral of the story then was that those who were healthy and well off should help the less fortunate, in this case the old and infirm. And Rulyov's account of home help was resoundingly positive and fit into these kind of state-impressed narratives of communist morality. But I guess the question here is what was particularly communist about providing this kind of community care. And so this kind of drawing on international examples to draw out this question a bit more. This kind of community-based support can also be found in other countries during the Cold War period, right? So one example is from New York, the Chelsea Village program, where you have, again, this kind of healthcare program that's designed for the homebound, isolated, and aged people. And this was something that was run out of St. Vincent's Hospital and originally staffed by 2 physicians, a social worker and a nurse. So the work of the CVP, the Chelsea Village program, is discussed in Philip Brickner's Home Health Care for the Aged, how to help older people stay in their own homes and out of institutions. Brickner was also the director of the Department of Community Medicine at St. Vincent's Hospital Medical Center. And now, like home health programs in the USSR, the Chelsea Village program relied on community and institutional support. So it was that sort of connection between these two. It also drew on the support of the homemaker, as well as housekeepers and health aides to provide domestic support to older people, right? So its function wasn't just medical. And Brickner includes an example then in this book, a kind of a sample of the official job description or job summary. And this describes the homemaker in very sort of gender neutral terms. But in the larger discussion around the homemaker, he uses feminine pronouns, right? So it was mainly women in capitalist and socialist societies who were expected to carry out this care for older people. And the type of expertise that was required in these cases was specialist, so nurse and social worker in the US case, and also non-expert in the form of domestic or homemaker skills. And so in the Soviet Union, it was mainly women, especially patronage nurses, who undertook much of the care work for older people. In a 1980 dissertation on services for old people in 3 towns in the Russian Republic, Larissa Chokrova from the Samashko Institute in Moscow noted that there were clear gender differences in terms of how care was delivered. So she said that, in her research, she was very precise, 9.1% to 12% of cases show that relatives were not in a position to help, and that women were twice as likely to provide help than men. And in the UK, around the same time, the Equal Opportunities Commission similarly concluded that, quote, women were key figures in providing support. And that research, again, in the UK showed that daughters and not sons were called on to care for elderly relatives, even if these daughters were employed outside the home. So gender and age inequalities, at least in relation to elder care, highlighted similarities in socialist and also non-socialist societies. So the second sort of case or example that I want to look at is coming from Ukraine. It's more moving into the mid and bringing us up to the late 1980s. So from the late 1970s through to the 1980s, the Soviet government released various sort of resolutions and decrees that called on, I guess, the community to kind of rally around older people and provide this kind of additional support. And a lot of the time it fell on the Red Cross to actually kind of implement these resolutions and decrees on a kind of a local grassroots level. So resolution number 436, then, this is from 1985. This is on improving measures for the material well-being of poor pensioners and their families and strengthening care for single senior citizens. So what this did was it called on the Red Cross to develop the patronage service, this is the nursing service, and to, quote, improve its interaction with social welfare, healthcare authorities, public organizations, and labor collectives. And so once again, women, and in this case, the patronage nurses, were called on to help older people. So these patronage nurses, again, which are largely women, who were often best informed, right? So they had this kind of, they had the interaction at local level, they had grassroots experiences. So their accounts and their reports are really useful in getting a sense of what was happening on the ground. And so one of these reports that is quite useful is from a patronage nurse called Kolesnikova. And she was one of 34 patronage nurses helping almost 2,000 people in Luhansk in Ukraine, which at the time was called Vargha. And she spoke at the third plenum of the Central Committee of the Ukrainian Society of the Red Cross, and this was in December 1987. So Kolesnikova was critical of the home help service that was provided to old people there. So she said there was, often there was no milk, no vegetables. There are transport limitations. There are problems with petrol allowances. So all these sort of logistical issues. But she also identified serious problems or flaws with the training that was provided to patronage nurses. So she said that, for example, these annual courses that were run by the provincial clinics and hospitals often didn't provide any kind of geriatric training. And so she called on the Red Cross to address these issues. But you can also see from Kolesnikova's account that patronage nurses had multiple roles, right? So they saw to the medical needs of older people, they provided social support assistance, domestic help with domestic tasks, but they were also active within the Red Cross organization itself, right? And tried to kind of improve, their working conditions as well as their training. And another example then, and this is also from the Ukrainian Republic, Manzhilevskaya, she was actually a health room activist from Dnipro, at the time Dnipropetrovsk, but she was also involved in this kind of outreach home help service as well. And again, she actually described herself as an invalid and also an old person, and she was active in visiting other older people and helping them with various domestic chores. But she also complained about sort of the lack of food, the availability of food to bring kind of food and supplies to older people in their homes. And similarly, she also pressed the Red Cross Provincial Committee to address a range of issues, but also she wanted them to encourage more activists in the community to help older people. So to wrap up then, women, whether as neighbours, as patronage nurses or activists, helped older people in their communities. Some of these women used their position to lobby the Red Cross to expand the range of services to older people. In many of these cases, the older people giving and receiving care were women. But I guess, and this is probably unhelpful ending on a question, but what was particularly Soviet about this kind of community care work, aside from these kind of ideological tropes about communist morality. And then in the broader Cold War story, the Soviet women shared commonalities with their capitalist sisters, right? So both American and Soviet women were expected to carry the burden of care, and for those suffering from chronic illnesses or those who lived alone. So I will end there. Thank you.
Thank you. That was a very interesting presentation. I think all of you made very interesting points. So for this part of the seminar, I will invite questions. These were very, very interesting presentations. So I don't know if the people that are connected, please feel free of turning your camera on and asking your questions, or if you have any issue, include them in the chat, and I can read the questions. Yes, Esther.
Thank you. Thank you very much for these very interesting presentations. I would have questions to all three of you. One to Rekha. I was wondering if you could elaborate a little bit on the intersectional aspects of your project. I mean, in terms of your approach, as well as maybe some of the findings that you already have. Then to Agata, this was a very interesting discussion of how family planning interwove with abortion law reform in the 70s and 80s. And I was wondering if, I mean, my question is about the gendered and class aspects of this, because your examples were from women abortion providers. Does this mean that they were in a majority, or were there also men abortion providers? And was there class background of any interest of these abortion providers, or it doesn't play a role? And then turning to Susan, I understood that your presentation is part of your larger book project that covers the whole socialist period. And I was wondering about your larger research questions and your sources, and maybe how this part that you presented relates to the longer history of healthcare for elderly in the Soviet Union. Thanks.
Thank you. Thank you for the questions. Shall we do this like a round of questions so everyone can respond? And then we have Teresa's question. Will that work? Yeah.
And I would ask perhaps, thank you, Esther, for your questions. So yes, intersectionality is both important for my broader project and for this specific chapter, basically, of the book as well, parts of a chapter. So race and racialization appears as one of the important aspects, as I am trying to compare racializing practices in doctor or nurse and patient encounters when it happens among women or among men, whether this makes any difference. So this is how race plays into this. And I also kind of mention some aspects as to how class comes in, because it looks like it has to do something with access. So women doctors had less access to these mobilities than women nurses because of the specific genderedness of nursing. But Susan Grant is much more of an authority on this subject than I am. On the other hand, where I find class in terms of the mobilities of medical professionals important is motivations. Because although for this specific case study, when I'm looking at the 50s and 60s, where financial incentives don't seem to be so huge, this is something that is going to shift toward the 70s and the 80s. And in the book, I'm able to deal with those aspects as well. And I want to figure it out whether it was more of an upgrade for nurses and operating room assistants than to doctors. Because in terms of chief motivations in these early years, we have anti-colonial discourses, we have solidarity discourses, not necessarily but there's an overlap. And then also I saw some sporadic mentions of escaping hospital hierarchies. So that for the doctors, that they didn't have access to certain types of operations because their superiors were excluding them. But when they were on the mission, where there was a chronic, like a chronic shortage of men and women power, there they were able to perform specific things. So this is a type of a motivation which seems to be class or let's say level specific in terms of the medical education. I hope I answered your question.
Thank you. Agatha?
Yeah, Esther, thank you for this question, and it gives me the opportunity to sort of maybe sharpen the conclusion, because of course it's a gender story and it's a class story, and in terms of openly politically so the people who are providing abortion, illegal abortion, but doing this openly before the criminalization, abortion doctors that were sort of the politicized providers, they were all men. And so basically these women are the first women who have sort of this public profile as abortion providers. And class works sort of both ways there, because they pertain to this generation of when medical profession in Spain is open to it becomes less elite and more democratic. This is a term that Angelica Fajardo, who studied that the history of healthcare in Spain in the 80s, used. So there's this democratization process. So it's studying medicine is more accessible, and these women pertain to this generation of women who have access to studying medicine to a larger extent, despite their gender, despite their class, no, because they don't pertain to medical elites. And on the other hand, class is this important drive behind or class solidarity, let's say, no, this projection of poor or underprivileged women as being in special need of having abortion access. Also because of this that much of the pre-decriminalization debate in Spain focused on this idea of abortion travel as a solution for wealthy women, and local abortion marketplaces not being of good enough quality to meet needs of poor women who are facing gender and class discrimination. So yeah, thanks for that.
Thank you, Agatha. Susan?
Yeah, thanks, Esther, for those questions. So in terms of the larger project, so yeah, this is part of a much bigger Welcome project, looking at different aspects of growing old in the Soviet Union. And so there were sort of others working on this project as well. So looking at, say, the experience of aging, the looking at sort of gerontology more specifically in the Institute of Gerontology in Kiev, to sort of examine the science of aging and also the kind of the international connections between Soviet and international gerontology. And I'm particularly focusing on healthcare. So this is the chapter that looks at kind of community care and voluntary work. And so in addition to looking at this home help service, I also look at, for example, health rooms and the work of patronage nurses more generally. But there are also chapters that look at care homes for older people. Examining that kind of the care homes, but also different types of geriatric services as well, and development of these kind of geriatric offices that arise sort of fairly sporadically in the late Soviet period. So it's really kind of putting that story of healthcare for older adults together. And then in terms of the sources, for this paper and also for the project more generally, I can draw on a range of published and unpublished sources. So the Institute of Gerontology in Kiev. So most of the research was done for this project in Russia and Ukraine in 2019 and 2020. And so I've used sort of periodicals, for example, for this Socialna Bezpieczenia, which is the kind of the social welfare, the official social welfare publication, but also a lot of journal articles and book publications on gerontology more generally. For archives, the State Archive in Moscow. Again, looking at kind of social welfare and healthcare, and also the Red Cross material. Similarly, when I was in Kiev, again, it was the Central Archive in Kiev that had sort of the Institute of Gerontology files as well as the Red Cross material. I've also more recently looked at archives in Latvia. Particularly at, again, different types of Red Cross services in the late Soviet period, but I haven't really touched on any of that material for this paper. So hopefully that gives you a better understanding of the sources and the project.
Thank you. Let's do Teresa's question, and then I will read Dora's question that are already in the chat.
Thank you. I think this goes very well because my questions actually only have one question for Agatha, and I see that Dora wrote questions for Susan and Reka, so we can do another round with everyone. First of all, sorry, I was late today. I had another reunion, so Reka, I missed your presentation. I'm very sorry for that. And Agatha, I got there. I think you had just started, but still, maybe my question was the first thing you said. In that case, I'm sorry. Because my question is, like for your Spanish case, you have a question mark, but nevertheless you call it socialist reproductive medicine. Why is this a socialist story for you, like in the Spanish context? That would be my question.
Perfect. So I will read Dora's question for Reka and Susan, and we can do the full round of questions. So for Reka, could you say something about the indigenous women, if they are part of the story encounters and perhaps solidarity among women or racial hierarchies? And for Susan, I was wondering about the receiving end of care. There is a different perception in the type of need of elderly women and men. And we can start with Agatha in this case.
Yeah, thanks so much. And yeah, and I really appreciate like the invitation to the seminar, because it really like allowed me to think about what I'm analyzing in terms of like pertaining or not to the socialist medicine paradigm, no? And I do think that it's both the healthcare reform in Spain and abortion law reform they are promoted by the Socialist Party. I mean, so this is the democratic transition when it consolidates, and with the socialist majority government in 1982, this sort of gives the ground for consolidating both public healthcare, national healthcare model, and this moderate abortion reform, both with this aim of making it accessible. It turns out it's not possible via public healthcare; it has to go through private healthcare. But it's promoted in the democratizing Spain by the socialist political movements, intellectual movements, healthcare movements, right? So I think it's really interesting to sort of inscribe also the Spanish story into this the socialist medicine as this idea and way lens of analytical lens, right?
Thank you. Vargha?
Yes, thank you, Dora, for this question. I think it's important to clarify both from a larger project and for this specific segment what role indigenous women play in them. So for this specific case study, the sources that I have only allow me to read about indigenous women through the eyes of Hungarian women and Hungarian men, and this is for that reason I would never claim that this is, for example, this is a global history type of analysis that I am performing here. This is really more about the Hungarian experience. In terms of the solidarity among women, yes, I really want to tease this out if that existed, and we could say that this is one of the kind of hypotheses, like beyond the bigger project, that there was some sort of specific women solidarity at play. But again, in this case study, I could only corroborate the Hungarian part. In terms of the racial hierarchies, especially since Bogdan Jakob's recent article about Czechoslovak and Romanian tropical medicine competition and this type of teacher-student relationship and that type of hierarchies, I find it very challenging to disentangle racial hierarchies from this already unequal situation where Hungarian doctors and nurses also go there to train the Korean future doctors, future nurses. So this is something that I'm struggling with, and where I again try to look at the language of the sources like very closely and to see how racial stereotypes are or are not somehow interwoven with this situation. But for now, what I could see in the AGO documents, for example, when one of these protagonists from whom I also included a quote, wrote about this training of Korean colleagues, and this it wasn't this type of civilizatory language that she employed. But again, I would be very cautious to extrapolate this to larger contexts. But in terms of the bigger project, there are some cases where I have access to sources, for example, socialist women's organizations in the Global South, where I have a bit from the other side of the story, but this will only allow me again to make these sporadic remarks, comparisons, but not necessarily to be able to formulate very overarching claims about either the racial issues or women solidarities. Thank you.
Oh, thank you. And Susan?
Yeah, so this was the question about, I think, if there was if there are different perceptions around whether men or women needed different types of care. And actually, you don't see it really so much in the home health service. And I think actually the care homes, which I didn't talk about, but which I examine, actually provide, I guess, a better illustration of this. where there isn't really a perception that there is a different type of care needed for men and women, for older men and women in this kind of more general context. So if you look at the care homes, for example, these are mixed, right? So you have only sort of a small number of those that are specifically for women. So men and women are, you know, they inhabit the same space in these care homes. So there isn't this sense that their requirements are vastly different. They're kind of treated the same. And I could kind of, there is another question there that might weave into this. I think it was from Sarah Howard, where she talked about childcare. But actually, I think it's from my perspective, rather than making a comparison between kind of the childcare and older people, I actually think it's more kind of productive and helpful to look at older people and disability, which comes up quite a bit. It comes up in some of the home care stuff and the resolutions and decrees, but also in terms of the care homes, where these again were mixed spaces. They were for older people, male and female, but also for the disabled. And again, these are all inhabiting the same space, and it's disabled of all ages, young and old. So I tend to look more to sort of questions around disability when looking at these kind of spaces for older people. So there, I think I've tied in two questions, hopefully.
But thank you, that really worked very well. Agatha, you had your hand, right? Okay, perfect.
Yeah, so I have a question for both of my panelists. So, and in both of your talks, the protagonists were, well, many protagonists, no, but in terms like professional engagement, there are these diverse actors. So in Reka's talk, it's doctors and nurses, male and female doctors and nurses, but then female doctors, women doctors, and mainly, I guess, female nurses. And then in Susan's example, in Susan's case study, there is this diversity of backgrounds, no, to perform this task. And I wonder, because the stories you told were more in terms of collaboration or sort of alignment, and I wonder about the conflict there, especially like illuminating this from the history of health profession, and health professions going really back to the sort of origins of women's medical, women doctors and scientific on scientific-based nursing, where there is not conflict, but there are these alignments between what it means to be a woman doctor, what it means to be a nurse, what are the roles, what is the possible collaboration, but what are also the hierarchies. So I wonder if this sort of pops at all in your material, or are you interested in exploring this?
So I thank you for the question. I think that will again go at the heart of the issue of class in a way as well, where I found maybe the most striking conflict, even if it wasn't formulated as such, but like through the sources, I still read them as conflict in the North Korean case. The fact that the doctors, they were always working at the hospital building, which was not necessarily the safest option during war, because like part of this assistance, like 3 years of it, was done in a war situation. But then once there was like a stone building, and it changed several times, Dora already knows this, still the doctors worked there, while much of the patient care was done outside in the villages. And it was most of the time the nurses and the operating room assistants who were actually more in danger because of very frequent like partisan actions. So in terms of exposure to these types of risks, there was definitely an imbalance, I would say. And again, sources are very scarce. I didn't see these formulated as a grievance, for example, because both of those sources that I included here on the slides, they were from nurses. None of these was narrated as a specific grievance, but somehow it's still read as such. When like moving a little bit away from the North Korean case, I have more conflicting accounts about, let's say, easy collaboration with local colleagues versus no, we are never talking to each other. We cannot do this. But there I don't see gender as a very good explanatory factor yet. On the other hand, because of this motivation issue and escaping the hospital hierarchies that I mentioned, I am very interested to see whether, when it comes to these very niche areas of medicine, where you have also very highly trained and highly skilled middle class, whether I can find, you know, like instances of conflict or of authority actually there. But it's an expectation, or it's a wish, but I didn't find them yet.
So yes, there are definitely examples of conflicts in my case as well. So you get this on sort of on ground level, where you've, I guess, in relation to sort of the demarcation of territory, but also in terms of training, where you have, you know, volunteers and nurses with different levels of training. So you have sort of conflict there as well. And I didn't really talk about this in the paper, but you see it in the project more generally, where you also have tensions and conflicts at a higher level, which then kind of filters down to kind of local, to the local level as well, where you have tensions between, say, the Ministry of Health and the Ministry of Social Welfare, where you have, and again, you have sort of different types. It's essentially about sort of training. When it comes to kind of care for older people, a lot of the time it's the Ministry of Social Welfare that is involved in overseeing this. And again, there are kind of tensions there with the Ministry of Health in terms of, you know, how this kind of care is delivered, and also prestige that for health workers who are working under Ministry of Health, the level of prestige is seen as sort of less than say working directly under the Ministry of Health. And again, that's to do, I guess, with sort of professional development in lots of ways. So it was considered better to be working under the Ministry of Health than the Ministry of Social Welfare, the Ministry of Social Welfare. So you have these kind of different levels. So you have the tensions and conflicts sort of right at the top that filter down into kind of the voluntary network. So looking at the different types of community care, but also then kind of also looking at care homes as well more broadly. So yes, there are kind of conflicts and tensions at every level in this story.
Oh, thank you. I think we still have time for one round of questions, and I really want to ask some questions. So I'm going to use this round, and if please someone else wants to ask questions, raise your hand or include them in the chat. But I have questions for all the presenters. I will try to be brief because I know that also we don't have a lot of time. So for Vargha, I have two questions, but they're kind of small, and I don't really know if there is a material to make a point on that. But I wonder, because you mentioned different missions, the one in Algeria and North Korea, do you have any material or evidence that these that for preparing for those missions, that there was interconnection and interlearning between what was happening in the missions? For example, did they learn from one experience, so the next mission will have a different capabilities, materials, etc. And the other question was about you mentioned that the people that were applying for this mission were mainly men, and that there was a strong preference for men. And I wonder if you can share some of the vocabulary used in the advertisement, or the imaging was much more based on the figure of the male doctor. I don't know, maybe you can add about that. That would be great. Agatha, I also have two questions. One was based on social perception. You mentioned that there were less female doctors, 20% in comparison to men. So I get that. But for the medical practitioners that wanted to learn how to perform an abortion and to perform an abortion, it was socially worse for them than for men. So it was a bigger of a stigma that a woman wants to learn or perform abortions. If you can share something about that, that would be great. And the other one was one of the final things you mentioned was this idea that the performing abortions will not be something that will be easy to do in the public sector. And then you mentioned the private sector as something, a facilitator, even though it is an arm because it's still paid by the state, right? So I wonder where that complementary kind of service started, and if that is a tricky way, a useful way to move around these type of barriers, problems, stigma. And finally, Susan, I had a question about the use of language between the different examples that you mentioned. For example, you had the idea of the wife circles and the wife skills, and then also the different language when you were talking about the district nurse that was in charge of these networks, or the medical auxiliary and the social worker. And I was thinking about the institutionalization of care. So where in the comparison of these systems, were some more professionalized, even though all were based on care and mostly performed by women, where some of these different systems making it more professional, and for that more not even profitable, but more like a more important role in society, more recognized and institutionalized. And the use of the word activist, for that's also by the final part of your presentation. Was the activist part a self-identification or an institution identification for women? Thank you. Yeah, very interesting presentations.
Thank you for the question. I will try to be very brief. So yes, there was interconnection, and perhaps that is best seen by several really outstanding biographies where you can see that people went first to North Korea at the end of the mission, so maybe 56, 57. Then they also applied and went to Algeria at the beginning of the 1960s. And they even made it to Vietnam at the beginning of the 70s. So you have this great arch, basically, of huge solidarity things. For the 50s, you have Korea, 60s, Algeria, 70s, Vietnam. And you do have some outstanding biographies where it's completely, and it's even framed like this, like a career in service of anti-imperialist solidarity. Unfortunately, these exceptional biographies that I have found, these are all men's biographies. So I'm still looking for examples from women. And actually, especially for this North Korean experience, it was such a community building experience to experience war and this after-war situation together, that a part of these doctors actually organized themselves, and then they kept on like following North Korean news even after the ties between the two countries cooled down a bit. And when the former party leader died, you know, toward sometime in the 80s, they issued even a statement, and they expressed their condolences, and then they also traveled back. They were invited back to North Korea. So it was very interesting, and they also gave presentations not only to their colleagues but also for different communities about their experiences. So there was definitely this. I didn't put an emphasis on that, but this deputy minister of health who had been coordinating these bilateral mobilities from North Korea onwards. He was a very, very important person who embodied basically continuity with his collaborate, another highly ranked administrator, who made sure that a lot of these kind of know-hows were actually like perfected along the way. What I would be very interested is to see the preparatory materials that actually these doctors received. I thought I knew where they are, but they are not there. So I'm still trying to hunt them down. And then that would help me to build a more robust or paint a more robust picture of this learning process and continuities. In terms of women's applications, men applications, and the advertisements. So the advertisements for these 60s, because for North Korea, I have no idea about the advertisements. I haven't seen them, but for the 60s, they are very sterile, very brief, very short, very neutral. But what I saw is that in their very brief biographies, women wrote much more about their family circumstances compared to men, but it was but there was no template. It just seemed to be a tendency that this is something that they did. And also I mentioned that there are very, very few traces of what the committee thought of the candidates who presented themselves, but I still found some of these documents. And one of the adjectives that comes up only for women candidates is conscientious. But this is not necessarily a bad thing, right? It's just that it's a feminized trait. It's a very gendered reading of the applicant's performance. But again, I couldn't really pin it down. It's very difficult to grasp through the sources. It's the result that suggests that there must have been some mechanisms that prevented at this early stage many women from entering. By the way, the biographies are very good, not only for this kind of emerging field of biography studies and writing histories based on biographies, but also for learning really about these personal motivations behind going. I read a lot of these arguments that I really deserve this. I excel at my field. I published at all these places. I've been applying for 10 years for some of the applications from later on. So this is really something that you should grant me. And these are very refreshing to read from the end of the 60s, beginning of the 70s.
Thank you.
Yeah, shall I? Yeah, okay. So yeah, thanks for that. And well, I'm sort of taking for granted that it was more difficult for women doctors to take the step to provide abortion services because of the like general stigmatization of abortion services in Spain in the mid-1980s, because I didn't mention that, but most medical professionals rejected, declared themselves tacitly or explicitly as conscientious objectors and rejected engagement with abortion services. So people who were doing that were really few, nation like country-wise, no. And amongst these people, there were even fewer women. So and these fewer women are also pertain to this generation of women that there's this huge leap from almost not a very, very tiny percentage in the 60s to 20% in the 80s, but it's still, so this acceleration of feminization is taking place, but still it's not as consolidated as, for example, in East Central Europe, right? So so I think there are potentially these intersecting challenges, and when I study the specific narratives and trajectories of the providers, you can see how they explain that it was there were these multiple intersecting challenges for them as first female resident in this service, and how how she was challenging the authority of her bosses and teachers, and how much of a sacrifice it meant, and how eventually they stopped, no? And then it's very interesting, this relationship between public and private healthcare in providing abortion services. And there are quite a lot of tensions as well between the different categories of providers, because especially because there is the provision of abortion in public healthcare continues to as very limited, and with private, but it's usually those people who are active in the family planning movement or are still in the public healthcare are quite not super enthusiastic about the private providers and their work. So they are sort of highlighting the economic gain of the abortion services, and they are highlighting sometimes the magnifying, or whenever there's some sort of complication that needs to be attended in a public hospital, it's magnified as a sign of poor quality of abortion services in some clinics. So there is this kind of debate. And on the other hand, the private clinics are with this idea of being assigned this task of guaranteeing reproductive rights for Spanish women for decades without proper recognition from their colleagues in the public healthcare, right? So there's a little bit of tension there. And this tension recently has become even more pronounced because of, and here the technology plays really a key role with the acceleration of implementation of medical abortion protocols in public healthcare in many Spanish regions. So, and this because Spanish healthcare is a regional prerogative of the communities, the autonomous communities. So there are still quite a lot of differences in how healthcare is delivered in some aspects, right? Because there is a common cartera común, so like a common list of services, but what is being funded, but then there are some differences still. And back in the 80s, it was even more pronounced. And for example, some of the communities such as Andalusia, they very early on, and the communities that were ruled by Socialist Party, the Socialist Party, they very early established this kind of agreements with private clinics, so the clients didn't have to pay. And this was not happening in other places under conservative rule, right? So there is this very clear connection there as well. But with the abortion pill, it's like this sort of tension is being more and more evident, because in public healthcare, many professionals are willing to accept medical abortion, and they have not been willing to accept surgical abortion or vacuum aspiration. So now public healthcare is also providing abortion services, and this tension is magnified because of concentration of one form of abortion services in the. So what public healthcare does, they provide surgical abortion for in malformation situations, so mainly surgical abortion in the second trimester. But what they are providing, abortion on demand, is via medical abortion, the pill, right, and not surgery. So yeah. Anyway, thanks.
Thank you. Yeah. Susan.
Thanks for those questions, Andrea. So the first one was about the institutionalization of care, and I'm just going to speak to the Sophia case for this. So yeah, it's interesting. By the time you get to sort of the late 1970s and the 80s, I think you see this kind of a move away from the institutionalization of care. And I think part of that is to do with the fact that you have lots of older people. It's the demographic issue, right? So you have these growing numbers of older people, a lot of them with a range of chronic illnesses, and institutions can't really cope with these numbers. So you have lots of shortages, so wait lists for care homes, hospitals not wanting to take in older people. So you see this increase in the kind of the outsourcing of care services, at least in the context of older people. And that also kind of connects to those resolutions and decrees that you see coming out in the 1970s and 1980s, where again, it's kind of calling on other organizations and groups in broader society to kind of take on this responsibility for caring for older people. So I'd say there's this kind of a move away in the late 70s and 80s from the kind of institutionalization of care. And then in terms of the activist and the sort of the language, I think the example is the Manzilevskaya, and so she self-identifies as an activist. So she introduces herself as, you know, this health room activist. I think that's probably kind of like a generational thing as well. So these were older people, you know, they were sort of the builders of communism, they were the new Soviet people. And so they use that language a lot of sort of activisty. So yeah, so this is how she described herself also as I think old and an invalid, but also an activist. And yeah, so that's you see that kind of language in some of these examples where they use some of those kind of official terms and identify with those.
Okay, thank you. If there are no other questions, I think we are right on time, which it's fantastic, really. I will say really thanks for your time and for the fabulous presentations and for the great questions. You need to know that these have been recorded, so we will upload this and I will share the link. So if you want to share it and circulate it, we can also do that. And thank you. Thank you for coming to the seminar. Hope to see you in the next one.